So we are going to have Harun Rashid, who's a vice president of UPMC International Services for business development, global care and passport care, physician services, and international telemedicine. So we're going to hear a presentation on telemedicine. Harun Rashid is also a member of our board of directors of the American Middle East Institute. He has been on several missions with us to the Middle East. We were in Egypt a couple of years ago, right during the World Cup. That was so much fun to be in this hotel right on the Nile, and this giant screen set up by the hotel to watch the World Cup, and then having all these meetings and conferences, and it was fabulous. And we've been to Oman, and there's just so many opportunities in the Middle East, and Harun is always ready to embrace new opportunities and to see where there is a potential to make a deal and come up with something that is really going to improve healthcare. So without further ado, Harun, if you would come up, and let's welcome Harun.
Thank you, Simon. Good morning, everyone. Being from Pittsburgh, this is wonderful because I know some of you have traveled long and far away to come to Pittsburgh. We appreciate all of you traveling from all regions of the world or around America. And it's especially great that we have beautiful sunny Pittsburgh in October. It's not raining, it's not snowing, but it could change by 2 o'clock this afternoon because that's how Pittsburgh weather is. But it's a beautiful city, and I hope you enjoy the city as much as we do. And many thanks to Simon for putting this event together, and the team. They've worked long and hard to get there. And one of the things that Simon wanted me to discuss is the global health telemedicine. And I was listening to the presentation for Saudi. I was just in Saudi about 2 weeks ago, meeting with King Fahd Medical Center and King Faisal Medical Center, and I'll talk about that. I mean, there's a great transformation happening in the Middle East. When I was in Dubai and I traveled around Saudi and all that, in terms of healthcare and what's happening, I mean, billions of dollars are going out of the country for treatment abroad, and with declining oil prices and the things that you heard Samir talk about, the country is refocusing on how can they become better at treating the population in country versus having to send them abroad. And we at UPMC believe telehealth is one of the vehicles to assist in that transformation of healthcare. I'm going to go through this at a very high level, and I'll be around if we need to have some further discussions around this. So just a basic in an ecosystem, what is telemedicine? And most of you probably know about this, but just want to give you an idea. There's 3 types of telemedicine that happens today. One is a store and forward, where you simply take a picture of a wound or something, send it to a physician. There's really not a patient-physician interaction as much, or a physician-physician. A lot of them is just consultation. The physician prescribes a medicine, and you really don't have a lot of interaction like you would do if you went to a normal, visit. So it's happening a lot through. Think of it as portals or other kind of systems in place. So store and forward. The second one is the interactive. This is where physicians are interacting with patients, or physicians are interacting with other physicians. So a lot of interactive. Think of something as simple as a Skype session that is happening to deliver medicine. And then the last one is remote monitoring. Very advanced, taking care of patients. As we transform our landscape to become population health centric and understanding how to take care of our population and keeping them out of the hospital in the United States, remote monitoring and others are playing a key role in the healthcare transformation to say, how do we manage patients and do a better job of keeping them healthy in their homes, so that they are not using high-end services like emergency room and other kind of treatment where we're doing a lot of unnecessary testings and so forth. So 3 types of ecosystem in there. And our journey, this is just a blurb of our journey, has really started around 2001. And this year, we will be exceeding well over 20,000 consultations that we are doing for telemedicine. And telemedicine, there's a norm that, you can only do certain specialties. Physicians will tell you, and that is true, because there are certain, if you're having a stroke, we definitely don't, well, actually stroke is a service we are doing telemedicine, so that's probably a bad example. But let's say there are certain services that you probably need to go to an emergency service vehicle, but there are services, both inpatient and outpatient, that you can utilize telemedicine, and we at UPMC are doing those things, anywhere from psychiatry to surgical oncology, fetal monitoring, and all of those things are all happening both in inpatient and outpatient. And we're just not doing this in a domestic setting, we're doing it as well in an international setting, and I'll talk about that. But this is just a blurb to give you an idea that telemedicine can apply to a lot of different disciplines, and it is slowly becoming one of the tools in the United States to provide care for patients that may need to travel 2-3 hours, and it's inconvenient because they're having to get hotels, they're having to take off work, and international patients even further difficulty having to come all the way to Pittsburgh or any other region in the United States. So let's talk about a little bit of international medicine and what we are doing around the world. As I stated, I'll try to fly through this, so I apologize because of the time constraint, but I'll try to get you some idea of what we are doing. Our mission from an international is that we really believe that everyone should have access to the best possible care without having to leave their country or region. Most healthcare institutions around the world, what you see is that they establish presence on the ground in a foreign soil, and it's really to direct patients back to the United States. Okay, that model is not going to be sustainable for the long term. We at UPMC really believe we have to go where the patients are, treat them in those home countries, and take care of them, collaborate with the physicians, and that's what our mission is, and that's what we actually practice, because you see the cast of characters that are there in the region, and we have to transform that landscape. We have to really improve that region so that they can better take care of those patients, because they can no longer sustain the billions of dollars that are going outside of the region to treat those patients. We're pretty much around the world, as you can see, and they could be anywhere from having a presence where we're managing a hospital, like in Italy. We have one of our transplant hospital in Italy. In Colombia, we have oncology hospital over there, 1,000-bed hospital. In Kazakhstan, we have oncology. Ireland, we have oncology, and the cast of character. In China, we are doing pathology. Some of these are also telemedicine. So we're pretty much established worldwide as a pretty dominant player in terms of our healthcare presence around the globe. And we bring several things to that. We bring hospital management, we bring clinical service management, we bring telemedicine, we have a health plan, UPMC health plan, and we have a UPMC enterprise, which you will hear Dr. Rashid talk about, which allows us to be able to provide commercialization of product with our partners to improve healthcare and best practice. So what's the benefit of international telemedicine, right? Why do you want to do it? Because not everybody can afford to send patients here or to affiliate with US-based institutions. It's expensive, it's costly, and it's also a lot of time consuming. So telemedicine is an entry, an easy vehicle. We use encrypted method, but it's something as simple as a Skype session. And we've done this in Kuwait, where we are working with doctors in Kuwait to evaluate pediatric patients pre-transplantation to see if they need to come to United States for transplantation, or through other vehicle can we keep them in the country and treat them in that country. And we do that through telemedicine, and we've done a couple of consultations like that, and that allows us to be able to assist those countries. The other piece of it is a lot of Middle East countries, when they send the patients here, if you look at the cost, only about 30% of their cost is really related to healthcare. The other 70% is living expense. On average, a patient from Dubai spends $250,000 for a treatment abroad for one case of whether it's ophthalmology, dentist, or something, because they're taking, caregivers, they're flying, their housing expense, and all of that. And so it places a huge burden. We can do this through the use of telemedicine to be able to say, pre and post, we can treat you in your country. And we're doing this around the world. Current state, what do we do when we talk about telemedicine? What do we provide to those institutions? So we do telehealth case review. So we're working with the physicians and we're talking to them about the cases, complicated cases. In some cases in Colombia, we're looking at every patient day in, day out because we're managing those services. We're doing telemonitoring. I talked about that a little bit. Remotely monitoring patients directly from Pittsburgh. And so, and you'll see an example of it where we're monitoring a hospital with 24-bed CICU directly from Pittsburgh, which is 3,000 miles away, without putting physicians on the ground. And our outcomes are greater than what the outcomes were pre-telemedicine. Virtual conference training. Training is a big need from an education perspective. We have great doctors in most of these countries. They do a great job. And most of them are trained sometimes overseas. They take those, skills, go back. It's the care coordination that happens that's missing, pre and post. And so we have to help understand, how do you take care of those patients before and after, and how do you get the nurses to achieve the degree of excellence that we would like to see to be able to make sure we have better outcome. Technical training. I'll give you an example. A particular country, a particular child passed away. If the child was put on ECMO, the child could have been saved. It was a high-level dignitary's child. It was identified that the country had 2 ECMO machines, brand new, sitting shrink wrap for 2 years. They didn't have anybody that knew how to operate the machine. Okay, so these are the kind of the challenges that we have to bridge. And through telemedicine, we bring them here, train, and then help them through telemedicine to say, here's how when do you bring a child on ECMO, when you take the child off. And that could be applicable to adult as well, not just children. Research collaboration, we learn a lot when we go and partner with the international institution. There's this thinking that, well, we're the best. Not necessarily. There are things that we don't see here in the United States as far as disease that we see overseas. And so it's a great experience for us to collaborate and partner with other institutions overseas and learn from them some of the disease that we may not see. Our fellows and physicians actually enjoy that interaction because it allows us to collaborate and understand what's happening in other side of the world in terms of healthcare that we do not typically see in this place. And then, of course, training again. So today, we're doing telepathologies around the world. Telestroke. Telestroke is something we do very well here. You have to react very quickly within 30 minutes or you'll have significant challenges in terms of stabilizing the patient and lifelong issues. We do telestroke in China. When they have a stroke patient, they're calling us and we're assisting them to understand how quickly we can put the patient on TPA to be able to tele-ICU. I'll show you an example of that. Behavioral health. Very important, neurodevelopment, rare disorder, and first and second and transplant. So this is just cast of some things that we do around the world. There's a lot more we do in terms of telemedicine, but I just wanted to explain to you that the severity and the degree of what we do and the complexity. Telepathology, the one we do in China, through our studies, we do about close to 900 cases per year for telepathology in one of the institutions. And what we identified is that 44% of the telepathology interpretation, once we have read it here at UPMC, the initial diagnosis by the physician on the ground in China had to be reversed because that was misdiagnosed, 44%. So that's a huge number that is now, we're helping them because they're misdiagnosing those results. I'll show you this in a little bit in a video, but this is an example of where you can, in Bucaramanga, Colombia, it's a 24-bed hospital. We have some in Brazil. We have one in Tampa. What we did is we started with telemedicine, the first journey, which is just doing a virtual collaboration. Now we're doing remote monitoring, which is a more advanced, and probably we're one of the few, if not the only pediatric hospital that's doing this 3,000 miles away in Colombia from the Pittsburgh, and we're monitoring everything. We're getting all the waveform, we're getting all the electronic health record, the images and all of that, and you'll see that in a video, and we're managing that. And then we publish, and we're doing several thousand cases over a period of time. But what is interesting is if you look in here, and I know it's kind of hard to look, before telemedicine was started, their length of stay was about 11, and for the hospital was 21. And we reduced that length of stay in less than 24 months to 6 for CCU, and hospital was 14. Their mortality was over 24% for pediatric mortality. Today, they're at less than 4%. So, it's very impactful because we're able to take part in assisting them and understanding how to take care of those patients directly from here. Components of telehealth. It could be, sometimes people ask me, well, what will it take to do that in my country or in my location and all? We do things like real-time audios, in-service training and all of that I talked about, but we need some of this. But in the absence of all of that, because sometimes they're mature. So when I was in King Fahd Medical Center in King Faisal 2 weeks ago, King Faisal is a very established, they're on Cerner, HIMSS Stage 7 in ambulatory site, so they're like us here in Pittsburgh, very advanced hospital. They will have all of these features and we'll be able to. And then there's another hospital in, let's say, South America, who has none of that. So as a physician, we need to have information. So you could do that with just a simple camera, a high-definition camera, zooming in, and that's what we did in some of the third world countries and Latin American countries, is to zoom in, look at all this information directly from here. So we didn't need to have access to the electronic medical records. We didn't need to have access to the radiology image because we could zoom into a camera and see it and make the interpretation here. But in advanced cases, we get access to that. So like in King Fahd Medical Center, we are going to start working with them to say, how do we build telemedicine capabilities where we advise you with your emergency room and cardiology and all these other systems, and they will be able to provide us that level of data. There's definitely challenges to telemedicine. When you're trying to do this across oceans, it's difficult. Bandwidth. Some of us here, we enjoy bandwidth like it's candy, right? So, but in some countries it's not that easy. I was in Brazil, and one of the hospitals, their bandwidth in the hospital was less than 100 meg for the entire hospital. And I asked them, I said, do you have wireless? They're like, yes, I have wireless. And they were very happy they had wireless. So they showed me there was one antenna for the entire hospital where you can't have that level because it doesn't aid in the capabilities to deliver telemedicine. So we have to have good bandwidth. We have to have physician acceptance. Sometimes as physicians, they tend to say, well, I know what's going on. I don't need another level of expertise. And that's true. So what we are saying is we're just a vehicle for you. If you need us, call us. And we're here happy to help you because we've seen thousands of these cases. And so we partner with the physicians. They're very, very important. Domestic and foreign laws, cultural issues, time zone issues. China, we've got to have people at night here. So we do. Stroke. If they call us at 10 o'clock at night or 2 in the morning, we cannot say, well, sorry, we'll call you back tomorrow. So we have doctors that speak, that are multilingual. We have doctors 24/7 that are doing those things. And so that we're able to provide this just like they would be here, right here in Pittsburgh. And so bottom line, what are we doing in telemedicine? We're achieving our common goals. We're providing international institution access to specialists. We're reducing the travel time. We have actually reduced patients from coming to the United States because we felt they could be treated better in their home countries, bringing the treatment home, improving the quality, providing the training, physician to physician. And this is important. In some places, you can eliminate duplicate or unnecessary procedures because we can tell you don't need to do all that stuff. And so telemedicine is a vehicle, it's a bridge to us that allows us to be able to connect that international location to our location and to really work together to improve the care of healthcare across all countries. So what we'll do is I'll show you a little bit of a video presentation in Colombia where we are doing a telemedicine consultation real-time live. So what you're seeing here is, right here is the monitor beds. We have cameras in every bed in the ICUs in that distant location.
So, AMEI. Have you seen this? Press it on the right spot. Stop.
The atrium, he went,
You need anything?
I think he went to the pulmonary artery. Artery, and he
Every
went
bed is monitored with a camera so that we can directly zoom in and see what's going on with the patient. We have all the vitals real time that's coming to us.
injected, and the contrast go all the way to one, and then he returns to the
Your face. Cardiac cath.
Yes, I said. So this disease is.
Total anomalous pulmonary venous connection.
Yes, yes.
Status pulse repair.
Yes.
But no good. Not good. Muchas gracias, Jenny. Muchas gracias.
Gracias, Jenicita. Hasta luego.
Hasta luego, que estuvo bien.
Okay, thank you. Questions? Yes.
We have a microphone for questioners. Jack, do you have a microphone?
Just say.
So, obviously, telemedicine is cost effective in the medical case of it. I can see lots of potential for physician-to-physician collaboration. But what about physician to patient? How did you build a long-term relationship in terms of interaction and negotiating treatment and follow-ups and that kind of stuff?
Right.
So
That's a very good question.
Yeah.
So the challenge you have in that is that unless you have a doctor-patient established relationship, you cannot directly, the laws prohibit us to directly interact with the patients. So the patient can be in the room with the physician, but we cannot directly interact with the physician. And there is a challenge too, because a lot of time those physicians are unwilling to treat if they find that the patient is seeking consult outside. And so what we traditionally encourage is that we work directly with the treating physician. So if you have a primary care or treating physician in your home country, we will do telemedicine directly with the physician. The patient can be there. The patient can interact with the physician, just not with us, because we're not, by law, we cannot directly interact with the patient because the patient has never come to UPMC. And if the patient came to UPMC, it's okay because now we have a doctor-patient established relationship. So a lot of it is physician-to-physician consultations. Yes?
So just a quick,
Sure.
and of course that physician-to-physician collaboration is also technology mediated. So has there been any work in terms of assessing the challenges of that aspect of that kind of conversation that's technology mediated between two experts? I mean, there's of course nothing better than in-person discussion. So.
Actually, you know, that's a question that I often hear is that, you know, are there, I find that physicians are more keen and actually do more checks and balances because they know they cannot physically touch the patient from here like they would do if you were in their exam rooms. So they tend to look at the notes more carefully. They tend to ask more questions, and they tend to make sure that they actually are providing the right diagnosis because of the fact that they're not nearby and they're not able to. So we always rely on the physician and the nurses on the ground to provide us with that level of information, but at the same time, we also, and patients actually like this. I mean, in the US-based market, we've actually had high degree of patients that have come in for their appointments using telemedicine and sometimes doing regular, because sometimes they, if they're especially in distant location because of work or caregiver issues, they tend to not keep their appointment. But in this particular case, they're actually seeing what the physicians are seeing through, if they're using an otoscope or something like that, and they seem to embrace that a little bit better. And the physician in the home countries also enjoy the ability to know that they have somebody to call upon on the other side. Sure. Yes.
Just a follow-up to the same challenges. We have done a lot of, attempted to do a lot of telemedicine in Cleveland Clinic, but I can't say very successfully. So there are many things like laws. For example, in China, not only you cannot talk to a patient, but you cannot actually recommend a medication, or you are liable. So you can talk to the physician, you have to discuss all treatment options. You cannot specifically say one. But I would say the biggest challenge for us is our own staff. And I don't know how you deal with it at University of Pittsburgh. So how do you get busy physicians out of their busy day schedule to do a telemedicine? How do you get them out at odd hours because of the time difference between here and China and here, or Middle East, and 6 in the morning, at midnight, and so on. So really the biggest challenge for us is us, not them.
That's a very good question. So like with everything else, it's people, process, and technology, okay? Most people tend to focus on technology. It's not. It's about the people and the process. We find that our physicians are very eager. We have a lot of foreign physicians, so they want to make a contribution to their community back home, and they participate very strongly in our international program and an international telehealth program, and they really work side by side. We call upon them. They're always willing to do so. And we've also, in some cases, created some reimbursement methodologies as well to incentivize some physician where we may be calling upon them more than 1 or 2 times. In the case of Columbia, I say, this is just like you are right here in Pittsburgh. Every day we have a physician going into that telemedicine room and seeing those patients for 1 to 2 hours plus 7 sites, right? So that compensation, not part of their salary, is tied to telemedicine budget. And in some cases, our physicians are, you know, I'm not saying that everybody's ready to come up and say, I want to do telemedicine, but we find that they believe in the UPMC international program. They believe that we want to make a difference, and it goes back to what my vision statement is, that we really want to keep those patients in their home countries and treat them. So we work with them side by side to ensure